Good evening, and welcome to San Antonio Regional Hospital's Orthopedic Community Lecture Series. My name is Janet Block. I'm one of the orthopedic nurses on the 4th floor here at the hospital, and I would like to thank you for joining us this evening. Our lecture tonight is Moving Forward and Living Better, Orthopedic Treatments for Shoulder Pain, that will be presented by Dr. Sachin Patel. Before we begin, there are a few housekeeping items. If you have a question, please utilize the chat box. Type in your questions and we will do our best to answer as many questions as possible at the end of the lecture. If you have a more personal question, please feel free to email me. My address will be provided at the end. It is now my pleasure to introduce Dr. Patel. After obtaining his medical degree at UCLA School of Medicine in 2000, Dr. Patel completed his orthopedic surgery residency at Albany Medical Center in Albany, New York. He also completed a fellowship in arthroscopy and sports medicine at the University of Massachusetts and Mass General. In addition to serving as the director of sports medicine at Casa Colina, he is currently the medical director orthopedic surgeon for the Claremont Colleges, Pomona Pitzer College, University of Laverne, Chaffey College, and the Webb School in Claremont. Dr. Patel is a member of the Gary Orthopedic Medical Group, a group of surgeons and clinicians who supported and served the Inland Empire for 30 years. Dr. Patel specializes in arthroscopic and reconstructive procedures of the shoulder, knee, elbow, wrist, and hip. We are grateful to have Dr. Patel here with us this evening. Welcome, Dr. Patel.
Thank you, Janet. Appreciate it. Welcome, everybody. It's my pleasure to spend a little time with you guys this evening talking about the shoulder, some of the causes of shoulder pain, and some of the potential solutions. One of my favorite topics is to talk about the shoulder because it is a very challenging joint. And there are so many different ways to manage problems around the shoulder. It's definitely one of the most common complaints that brings patients or people into their primary care physician's office. Certainly one of the most common things to funnel into my office. And there are various causes, so many different reasons why people develop shoulder pain. And it's a challenge sometimes predictable to figure out exactly what's going on and come up with a management plan. The problems that arise in the shoulder are definitely age dependent, activity dependent. Sometimes different types of sports cause specific types of shoulder problems. And it's fun to try and categorize some of the different problems in the shoulder based on these different categories. And sometimes that can help guide our diagnosis and ultimately our treatment. It's not rolling. There we go. So one of the most common questions I get first is, well, I don't know what happened. I woke up with shoulder pain and it's been bugging me for a few weeks. Well, what happened? Well, it's not always clear to say. It's not always easy to say, but it's our challenge and our charge to figure out what's going on. More often than not, there's some element of inflammation, whether it's a bursitis, a tendinitis, or some other cause. Sometimes there's an element of instability, dislocations or lack or apprehension around the shoulder at the glenohumeral joint or at the acromioclavicular joint. And we'll go into some of the anatomy in a little bit. We always want to make sure that there's no element of fracture. Hopefully there's an explanation or some mechanism associated with it, but there isn't always. You can have fractures, the greater tuberosity, the head of the humerus, the glenoids, different parts of the scapula. And of course, the most feared at times, I would say, is arthritis. And it seems more like a doom and gloom type of topic, but at the same time, certainly one that can be managed. I love the shoulder mostly because it's very complex. It has a lot of different muscles and bony contours, and it's not always obvious as to what's going on until you really truly understand the mechanics of the shoulder. And I like this slide because we have a handful of critters here that that have been in the different stages of evolution of the shoulder. And if you think about it, the shoulder is the connection between the central portion of our body to our appendages and let us reach out into space. So it's the connection between the two, and it is by definition responsible for mobility. And this critter up at the top, in the top left, is what's called the Tiktaalik. It's one of the creatures that was theorized to be one of the original animals that came out of the sea and onto land. And initially, its limbs were developed from a cartilaginous to an osseous form. And at the top right is more of a land mammal that evolved from this and had the ability to walk on land and climb. And interestingly enough, the mammals in the ocean today, whales, dolphins, etc., they evolved from land mammals and went back to the sea. And the structures that are in the shoulder girdle and the shoulders of these creatures still have homologs of the shoulders that we still see today. And then looking at the transition from quadrupeds to bipeds is also a very interesting line of study in how the shoulder actually developed and changed to suit our needs and function. The actual shoulder girdle itself is primarily comprised of three bones. Centrally, the scapula, which is a very odd-shaped bone to accommodate the articulation with the thorax or the rib cage. And then you have a long, thin strut bone, the clavicle or collarbone, keeping the shoulder blade, the scapula, out in space and along the rib cage. And then, of course, the upper bone in the arm, which is the humerus, and having its articulation with the glenoid at the glenohumeral joint. And then the clavicle articulates with the acromion at the acromioclavicular joint. So those are the two main joints in the shoulder itself. And technically, you can call the articulation of the scapula with the rib cage somewhat of a joint because it is mobile. It's the glenohumeral joint itself is very different than, say, the hip joint in that it's inherently unstable. Unlike the hip, which has a very deep socket and a large spherical head, this is somewhat stable. On the other hand, the glenohumeral joint has a very large head and a very small, shallow, dish-like or saucer-like joint, somewhat akin to a golf ball on a tee. Doesn't take but a little breeze to knock that ball off. Same thing in the shoulder. We rely on multiple soft tissue structures to provide stability in the shoulder, namely the capsule, the rotator cuff outside that, and then the outer envelope muscles, the deltoid, the trapezius, and the pectoralis. So if we take a look at some of the osseous anatomy, here is the actual glenoid or the socket of the shoulder, the humeral head itself, both of which are covered with cartilage like all joints. And you also have this portion right here called the coracoid process, then the acromion itself up top here, and then the humeral shaft, the humeral neck, and the humeral head. And I might refer to some of these different anatomic structures as we go along. Just outside the actual shoulder joint itself is what's called the capsule, and it's a thickening of fibrous tissue that helps contain the humeral joint or the glenohumeral joint, and it helps keep it in place. And there can be different forms of pathology that cause stretching or tears in this capsule, which somewhat compromise the stability of the shoulder itself. You can also see all these different little straps that help keep the biceps tendon in place. In addition, there are tendinous attachments, the rotator cuff namely. Here are the rotator cuff muscles. There are 4 primary rotator cuff muscles. And if you have any shoulder pathology and you have a discussion with your surgeon or you spend a little time reading about it, you'll learn them very clearly. The supraspinatus is one of the tendons and muscles at the very top of the shoulder, probably the most frequent source of pain and areas of tears. You have the subscapularis, which is in the front of the shoulder, coming across the chest. Behind the shoulder, you have the external rotators, or the infraspinatus and the teres minor. And these are the ones that rotate externally. The outer envelope consists of the pectoralis major, the deltoid on the outside, laterally to the lateral side of the shoulder, wrapping from the front all the way around to the back. And in addition, you have your trapezius posteriorly. Now, one of the more common areas to get inflamed in the shoulder, and it doesn't take much, maybe sleeping incorrectly or sleeping in an awkward position, maybe doing a little too much yard work, sports, can really irritate some subtle areas of the shoulder. And you frequently heard about people talking about having a bursitis, and there are different bursal sacs around the shoulder. And a bursal sac is simply a small sac of fluid that helps lubricate or pad motion between areas that move around the shoulder. So if you take a look here, this is a subacromial bursal sac, and that is a small sac of fluid between the humeral head and the overlying bony shelf called the acromion. So when you move the shoulder, instead of the humeral head grinding on the undersurface of the acromion, you have this little sac in between to cushion. In addition, you can have these bursal sacs between the capsule and the rotator cuff tendons themselves. You have them all over your body, between the skin and the bone, over your elbow, over the knees. So there are areas that are prone to irritation and inflammation. Tendons, as you probably already know, are the connections between the muscular portion of the rotator cuff and the bone itself. And it's made of a much denser fibrous tissue than is some of the other structure around the shoulder. So it's a very thick, strong material, but it's also prone to inflammation, irritation, and tears. So repetitive overuse, heavy lifting, pushing, pulling, that can cause irritation and inflammation in these different tendons. Sudden sharp yarding, that kind of thing, can also lead to inflammation or tears. Micro tears within the substance of the tendon can lead to inflammation and pain. And so sniffing out some of these different sources or mechanisms of injury to the areas can help clue us into the different structures that are affected. So of course, this lends itself to discussing, how do we manage inflammation? Of course, it's easy to reach for some of the oral anti-inflammatories, over-the-counter NSAIDs, the classic COX-1 inhibitors, ibuprofen, naproxen, the prescription-based COX-2 inhibitors like celecoxib, and then the classic salicylates, which is aspirin. But don't forget RICE, rest, ice, compression, elevation. Especially when the symptoms are early, this is still a valuable approach to managing areas that are really irritated. So let things settle down and prevent things from getting worse. So you don't have to end up using more aggressive means to try and manage this. Oral steroids are typically reserved for much more intense pain, sometimes for longer standing problems that are causing inflammation, and that can be used, but have to be used very carefully, of course. Cortisone injections are a popular and common form of reducing inflammation, and we'll go over a little more detail about that. And other dietary supplements and biologics, which we'll discuss in one of our other lectures coming up. Well, cortisone injections, frequently people will call and make an appointment just to get a cortisone injection into their knee, into their shoulder, various areas that are irritated. And what exactly is cortisone? It is a steroid, and it's a very potent anti-inflammatory. And we like to use cortisone in very select settings to help reduce some of that when more conservative means haven't been helpful. And what it does is it reduces collagen and inflammatory enzyme production, which in turn leads to more inflammatory responses. And sometimes those inflammatory responses are helpful in the healing process, but at the same time, one of the side effects of it is pain. Certainly does not solve the underlying pathology. It's not a pain medication, and it's not an immediate remedy. It usually takes a few days to kick in because it's changing the biochemistry of your body rather than inhibiting a pain-mediated pathway, for example. Typically takes 5-6 days for it to kick in. If after a couple of weeks it doesn't help, it probably won't. And of course, overutilizing cortisone can be a problem. Injudicious use can result in infection, deposition of crystals into the actual joint, into the cartilage. Not uncommon to open a shoulder or a knee and find tons of crystalline deposits from multiple cortisone injections over the years. And it can also lead to local loss of bone density, which can be a problem, especially if you were planning on doing some bony work later on. And so it's a good occasional rescue, but it's certainly not a good long-term management option. And physical therapy is one of my favorite modalities to help with managing some of the problems around the shoulder. Because of the complex nature of the different muscles, the joints themselves, the bony architecture, it doesn't take much to throw the entire shoulder out of whack and cause pain radiating up into the neck, down into the arm and into the elbow. And so to help restore some of the joint mobility and flexibility, some guided therapy can be very helpful. And having the discussions not only with us in the office, but with our knowledgeable and experienced physical therapists, you can identify and help change some of the poor habits that lead to some of the problems we encounter. And the whole goal is to restore and maintain all the flexibility and mobility, but also to promote the strength and conditioning of all the different components of the musculoskeletal system: muscle, tendon, bone. Well, the feared rotator cuff tear. This is an arthroscopic picture of a tear of the supraspinatus, and this is the very edge of the supraspinatus where it's torn away from the greater tuberosity or the edge of the humeral head, leaving a gaping hole in it. And that leads to certainly weakness because you don't have the function of the supraspinatus pulling on the humeral head to help rotate or to elevate the arm. And so generally with a large rotator cuff tear like this, in order to restore its function, if it's done in a timely manner, it can be repaired and restored and fixed in such a way that it allows the tendon to heal back down to the bone. And if you do find yourself with or faced with a rotator cuff repair, this is generally what it takes. General anesthesia in an operating room. You're basically sitting either in a beach chair or on a side-lying position, and through multiple small arthroscopic portals to use a camera to guide and visualize the different structures and small instruments, you can repair the rotator cuff. And that buys you about 3 or 4 weeks, maybe even longer, in an abduction brace like this, followed by some physical therapy. And one of the common questions are, well, what do the anchors that you use look like when doing a rotator cuff repair? There's a nice picture of them. They're basically a small screw fitted with some sutures that come out the back. And those sutures are routed through the tendinous portion of the rotator cuff. The tendon is pulled back into place and then secured with these small anchors. And the anchors are typically made of different types of plastics, and they can be made of titanium as well. Some plastics are bioabsorbable, so they completely disappear after months to years. Some of these plastics are permanent. The titanium typically is permanent. And so here you go. This is a small rotator cuff tear, and there's different techniques you can use to sew the tendon back together, pull it back over down to the bone, and secure it. And ultimately, these rotator cuff repairs are predicated on healthy tissue. So degenerative tears often result just purely from aging, not uncommon in smokers, very common in diabetics. So maintaining a healthy lifestyle and keeping diabetes under control can help prevent these things from arising. But they often come from trauma as well. So after a rotator cuff repair, you have the sutures and you have the anchors doing most of the work, keeping that tendon back in place. It takes time for the tendon to heal back down to the bone. And so after a few weeks to a few months, it's a shared load. The rotator cuff itself is starting to heal. It's doing some of the work, as is the hardware that's been placed. After a few months, 6 to 9 months, that tendon is for the most part healed, and the anchors and the sutures are really not doing a whole lot. And generally, unless there's a problem with the hardware, it's left alone and it's part of you. The other structure that can also be affected in the shoulder is the biceps tendon. And it's a fairly fickle structure because it's a long cord-like structure that starts inside the joint, exits out this interval between two of the rotator cuff tendons, and then comes down and forms the biceps muscle that's easily visible in the front of the forearm, or of the front of the upper arm. And here's this top left picture is a picture of a normal appearing tendon diving down into the bicipital groove. This is another picture showing the biceps tendon coming off the top of the glenoid and then reaching out into the biceps interval. And this is a pathologic biceps tendon. You can see a lot of the fraying, and it's not detached or truncated, but it's frayed and irritating. And this is a significant pain generator. And the reason this biceps tears like this is because it's constantly gliding in and out of the shoulder joint with rotation of the shoulder joint, or the rotation of the shoulder itself. And when there's pain like this, there are different things that you can do to help calm this down. In the end, when you have a significant enough tear, the surgical means is to truncate the tendon and reattach it outside the shoulder joint. And then this is what that would look like. Sometimes this is done at the same time as rotator cuff repairs, because the location of this biceps tendon, which runs right through here into the groove, is immediately adjacent to the most commonly affected rotator cuff tear, with the supraspinatus immediately adjacent to it. So the pinching process or rubbing process, impingement underneath the overlying acromion, can affect both. So doing a tenodesis at the same time as the rotator cuff repair can also help with relieving some of that pain while maintaining that contour, which is so important to us, so we don't look so asymmetrical. Shoulder stability is very important. Like I was mentioning earlier, it's inherently unstable. And without the soft tissue stabilizers or the static stabilizers of the shoulder is going to dislocate. And so this is a picture of an anterior shoulder dislocation. The humeral head is out of the socket, which is right here. And in order for this shoulder to come out, typically it's going to either stretch the capsule and tear the labrum, or one or the other. And it's fine and dandy to be able to put the shoulder back in place, but what you don't see is the trauma that's happened to the soft tissue structures that surround the shoulder itself, the capsule and the labrum, namely. Here's a young athlete sitting in his training room, maybe a bad tackle, open-armed, and he's got a shoulder dislocation, and the humeral head is sitting in front of the glenoid, and you can see this concavity of the subacromial space where the humeral head is sitting lower than where it's supposed to be on this side. When it comes to fixing that problem of shoulder instability, we have to think about different means. Of course, physical therapy can always be tried, and we start to look at shoulder instability in age groups. Under the age of 25, after a shoulder dislocation, the recurrence rate is really high. We're talking over 90%. So you have a football player, hockey player who comes in with a shoulder dislocation, you get it back into place, you start some rehab. Even down the line, under the age of 25, there's a significant chance of recurrent dislocations or recurrent instability. And that's because that capsule, the capsular structure, the static stabilizers around the shoulder, in addition, the labrum itself has been compromised. It can be a tear, it can be stretched out, and there are surgical procedures such as, for example, demonstrated here, that can be done arthroscopically to repair the labrum itself and tighten the capsule if necessary. So here's a camera, small anchors with sutures lashing the labrum back to the glenoid itself. Other forms of injury around the shoulder, typically very dramatic. Usually this is off of a bicycle, motorcycle, skateboard, landing directly on the shoulder. So going head over heels, driving the shoulder into the ground, causing a separation between the clavicle and the acromion. And when it's significant enough, it injures the actual joint capsule between the acromion and the clavicle. In addition, you can rupture the ligaments between the coracoid and the undersurface of the clavicle. When this sort of injury pattern happens, there can be a lot of, number one, it's very painful and can have consequences down the line with respect to instability. So here's a classic picture of a grade 3 acromioclavicular separation. Looks like the clavicle is sprung up, but actually it's more the whole shoulder girdle is sagging, whereas the clavicle is basically in its normal position. And so in this picture, you can see the capsule around the acromioclavicular joint has been torn, and the corticoclavicular ligaments between the coracoid process and the clavicle, they've been ruptured. So there's an increased space here and here. Not comfortable, certainly can be a problem in the long term. Doesn't always require surgery. Rehab can often manage this without leading to anything surgical. But in our overhead athletes, overhead laborers, electricians, construction workers, often the stability of the shoulder overhead is predicated on stability of this area. So surgical procedures have been devised in order to stabilize that. So this is a cadaver graft looped around the coracoid process here, passed up through the actual clavicle itself, and then backed up with some high strength suture. And that allows scarring and tissue to heal between the clavicle and the coracoid and provides a nice stable joint. When you have a rotator cuff that is left alone and ignored or never identified, sometimes the rotator cuff gets to the point where it's unrepairable. And often associated with that is atrophy of the muscle, excessive scarring and retraction of the tissue to the point where you can't pull it back over to restore its anatomic position. When that happens, the humerus itself starts to ride up and grind on the undersurface of the acromion up here. When this starts to happen, active motion is compromised. Instead of being able to raise the arm overhead in a nice smooth fashion, the deltoid pulls on the humerus and causes more of a shrugging motion. Instead of one of the things that can be done instead, if the rotator cuff isn't repaired when it's repairable, there are some other options. One of them is what's called a superior capsular reconstruction. And in this picture, you can see this tissue right here, which can be either cadaveric, meaning donated tissue, human, or some type of synthetic material. And instead of reattaching the rotator cuff tendon back down to bone, this is used as a limit or a limiter to superior translation of the humerus. It's sewn down to the bone with anchors and suture on the medial side at the glenoid and also on the humeral side. And it serves as a restraint from translation. So the outer envelope muscles, the deltoid, when it activates and tries to raise this, raise the humerus up, it allows this to maintain the concentricity at the actual joint and allow rotation at this joint rather than translation. And this is a pretty significant procedure and very valuable, particularly with patients with these long-term, long-standing rotator cuff tears without much arthritic change. In patients who have significant arthritis associated with this problem, this is not generally a very useful procedure because the pain associated with the arthritis isn't addressed. More recently, over the last 10 to 15 years, some other devices have been developed and have been used in Europe, probably over a decade by now, to serve as a spacer between the humeral head and the acromion. It's just over the last year or two starting to get into the US and working its way through the FDA approval system. And there may be some use for this in the coming years. The indications are not perfectly identified, but basically what it involves doing is putting in a small balloon filled with saline and creating a cushion between the humeral head and the acromion to allow restoration of the concentricity or the articulation between the humeral head and the socket. And this can potentially allow restoration of some of the motion around the shoulder. More likely than not, this will probably be used to help eliminate pain basically at rest. Probably not going to be a useful procedure to do for younger patients who are looking to get back to overhead lifting or laborious work overhead. But this is basically what it looks like. It's a small flattened disc with that's filled with saline. It's installed in the subacromial space, and then filled and insufflated with saline, and serves as a buffer and a cushion. So I think it's a potentially valuable device, but still in its early stages in its implementation. There are no big long-term studies showing success, but initial studies I think are favorable. In the long term, when none of the other options are available or are appropriate for an arthritic shoulder, we start to consider shoulder replacements. And of course, similar to hips and knees, that typically involves resurfacing the actual joint surface on the glenoid side, the socket, or on the humeral head side. And in this picture, this person has a very large inferior humeral head osteophyte or bone spur. All the articular cartilage or the joint surface has worn away, and this person is grinding bone on bone. Often this leads to pretty significant pain, limitation in range of motion, inability to get the arm overhead. And in this situation, with conservative means not being helpful or having failed conservative means, a total shoulder can be considered. And this is a picture of a standard shoulder replacement or an anatomic shoulder replacement. In order to do this and have it succeed, you have to have an intact and functional rotator cuff. And what you do basically is cut away the humeral head that has the affected portion or the affected joint surface on both the humeral and the glenoid sides. And you implant a plastic liner in the glenoid and then a metal surface here. And then you can see a humeral shaft or a stem down into the shaft. And this can be cemented into place if the bone is not very good. Other times, if the bone is adequate, you can implant this and get a press fit, so no cement is needed. But this is entirely predicated on an intact rotator cuff. When that rotator cuff is gone, you see the humeral head shifted up, and you have a significantly arthritic shoulder. There's no articular cartilage left. There's a large inferior humeral head osteophyte. You have a rotator cuff insufficient and arthritic shoulder. Then one of the other surgical options is what's called a reverse total shoulder. Rather than the socket being on the glenoid side, the socket is installed on the humeral side, and the ball or the spherical portion of the construct is on the glenoid side. And this works and was designed many, many years ago, initially when shoulders were first designed or shoulder replacements were first designed. It's not a new idea, but the implants themselves failed frequently, so it was never taken into mainstream. Over the last 15 years, the technology behind the implants and understanding the actual surgical techniques have been improved enough that these actually have a very good longevity, upwards of 15 years now. And the idea behind this is the rotator cuff is long gone, so you don't have the concentricity of the humeral head. There's no force to keep the shoulder in place. So you have to take advantage of the deltoid muscle, one of the outer envelope muscles. And if you don't change the instantaneous center of rotation, then the same thing is going to happen here. That deltoid is going to pull the humerus straight up. So if you medialize the center of rotation of the shoulder, then that deltoid has mechanical advantage and can rotate the humerus rather than translating it up superiorly. That's the biomechanical idea behind a reverse total shoulder replacement. So all of these different surgical procedures can be considered when conservative management fails. And it's up to you as a patient to start doing a little bit of research ahead of time. And I always encourage my patients to come up with ideas and thoughts and then to run them by me. And so I can either dispel myths or guide them along and provide some different options that are appropriate, specific to not only their goals, but to the anatomic findings. And one thing you probably noticed, maybe you did, I didn't show any MRIs in this talk. And I think that MRIs are very helpful, but the majority of time with a good history, a good physical exam, and a decent set of x-rays, I usually know what kinds of options are going to make sense for these different situations. MRIs are very helpful in identifying some subtleties and specifics to anatomy that might change how I go about doing each individual procedure. But I think it's an adjunct more than anything else. But if you do have specific questions on what types of procedures, and each one of these have many variations, each of these procedures, and it's surgeon dependent based on experience, available implants, and ultimately what makes sense on each individual basis. So questions about these implants and techniques are always welcome. It's a fun discussion. I enjoy it. And I hope this helps give you guys a perspective on some of the different procedures that are out there in the long term. But I always will encourage trying to avoid things that tend to aggravate the shoulder. But the goal of these treatments are to help you reach your goals. And you look to us to guide you on that. Hopefully that was helpful. And I open it up to questions.
Thank you so much, Dr. Patel. Both impressive and informative. Now let's go ahead and transition to the Q&A portion of the lecture. It appears as though we have about 5 questions from our viewers. The first question that we have is, how do you feel about Orthovisc injections for the shoulders?
It's a very good question. Orthovisc is commonly known as a lubricant made out of hyaluronic acid. It's FDA approved for its use in knees, but not in the shoulder or in the hip. That doesn't mean that it's not potentially helpful. It just doesn't have the FDA check mark. It works technically as a lubricant. You take advantage of its viscosity to help with motion in the joint where you have basically grinding of bone on bone, essentially. Even in mild cases of arthritic change, there's probably significant benefit to it. It's not a long-term solution, and it would potentially be temporary at best. If it in and of itself, it does have some pain relieving properties, the mechanism of which is completely unknown, but it can be a segue or a way to buy some time. But it's generally not something that would be useful in the long term for arthritic change. But that's generally the situation you might consider it in.
A follow-up question to that is, does Medicare cover Orthovisc injections for the shoulder?
Again, it's not FDA approved for use in the shoulder. So unfortunately, no.
Okay, thank you. Next question. What is the best thing I can do after surgery to help with my healing process?
Well, it definitely depends on the actual surgical procedure, but certainly following our guidelines as surgeons, we know what tends to cause more problems and areas of where you can really get into trouble after different procedures. More often than not, there's going to be a rest period after surgery. And so in order to balance some early range of motion with protecting, say, a rotator cuff repair, things need to be guided. And so the help of a physical therapist and guided range of motion and strengthening really does make sense. So protecting the repair or the reconstruction, say in the total shoulder, for example, is vital. Things can go wrong after big surgeries like this, and it's much more difficult to go back and revise something than it is to do an index procedure. So following guidelines definitely makes sense. Maintaining a healthy diet so that your tissues heal adequately. Anti-inflammatory medications can be really helpful when tolerated properly. Keeping your diabetes under control is vital. Patients whose blood sugars start to run high run a much higher risk of infection, which is a disaster in any surgical setting. Those are probably the most important things. But at the same time, also enlisting the help of family and friends to help with the recovery process. No one can go at this alone. I certainly can't do all these procedures without all my staff and the help that I have. I would never expect a patient to be able to get through these procedures alone either.
So very true. It does require everyone's input and a team effort. Next question, how soon after surgery will I regain full range of motion?
Excellent question. The overall timelines for starting physical therapy and starting the range of motion vary from procedure to procedure, of course. But generally by 6 weeks, I start the process of pushing the range of motion a little more aggressively with the help of the physical therapist. You start with passive range of motion, meaning somebody's moving your arm for you. Once you start to retrain the muscles to wake up, then it's an active assisted range of motion process. So you're working on it, getting some help with that range of motion, and that takes at least a month or two. So it's not uncommon to take upwards of or up to 3 months before you're able to get your elbow overhead, whether it's a shoulder replacement or a rotator cuff repair. Even if you're able to get your arm up overhead within a couple of months after surgery, you're probably not going to have a whole lot of power or endurance. And so there's going to be a fatigue factor, and restoring that muscle strength and endurance is going to take some time. I anticipate most of my patients after a shoulder replacement to have most of their motion back by 3 months. Rotator cuff tears, they can take sometimes up to 6 months in a large tear, especially when you're protecting it for a longer period of time. So if by 6 months I don't see adequate range of motion, I'm watching very carefully, and I might be a little more aggressive about increasing the physical therapy process. But most people are very functional by 6 to 9 months, and whether it's a shoulder replacement or a cuff repair. And the nice part about it is even beyond a year or up to 2 years, you're going to continue to see improvement. So even though 6 weeks seems like forever, it's really just the beginning of the process of restoring all the function and getting back to the activities that you once used to be able to do.
The next viewer wants to know, as a climber with shoulder arthritis, is there a surgery that will allow me to keep climbing? I've heard it described as a hemi.
There are various procedures, again, like we had talked about for the arthritic problem. Hemiarthroplasties basically address only the humeral side and leave the actual joint alone. Or leave the glenoid alone. And there are times in appropriate situations where that might be helpful, but it still requires an intact rotator cuff to restore that range of motion. It will most likely be a hemiarthroplasty will most likely be a temporary solution. For someone who's as active as you are as a climber, at some point that humeral or the glenoid side will probably start to wear out, and that hemiarthroplasty will probably need to be converted to a total shoulder replacement. At some point, it will hurt. But the real question is that you were probably looking for, or the real answer you're looking for is, will you be able to climb after such a procedure? And that is very difficult to predict. Not only are you out in different spaces than most people are, reaching behind you is very difficult to get back, especially with your weight at various angles, trying to keep up against a wall. I generally don't recommend trying to go back to climbing, but at the same time, it's not out of the question, and people have been able to do it.
You may have answered this question already, Dr. Patel, but a viewer is asking, approximately what is the recovery time for a reversal shoulder replacement for an elderly person?
I think it's actually still very similar to the younger population. I would say most people by 3 months will have most of the range of motion overhead that they're going to get. They'll still see improvements, but the majority of the progress is in those first 3 months. Most people are very functional with activities down below the level of the shoulder easily by 6 to 8 weeks. So within a couple of months, it's the overhead motion that takes the time. And the other nice part about it is the pain relief. The pain relief is significant and noticed immediately. It's not to say that a patient can be completely pain-free within a couple of months. There still will be discomfort as the recovery process goes on, but the change is pretty readily apparent right away.
Next question. Do you recommend taking collagen supplements?
There is certainly no literature that supports it, but most people tolerate it very well. And even if these actual supplements do provide some symptomatic relief, it's okay to do so. And there's no drawback to it. And, I certainly do advise my patients, if they are having discomfort and are looking for alternative means to some of the more aggressive procedures, that things like hyaluronic acid, glucosamine, chondroitin, these are all building blocks for proteins that can be helpful. And the actual mechanisms by which they work are certainly not completely understood, but have been shown to be helpful. And again, they tend to help manage symptoms.
Okay, this is our final question. How do you determine which shoulder replacement to do, traditional versus reverse?
Again, an excellent question. And it's primarily predicated on the presence and function of the rotator cuff. Interestingly enough, the anatomic shoulder replacements, you need to have a functional rotator cuff. So most patients who have recent loss of range of motion, significant arthritis, but have good rotator cuff strength and function otherwise, are good candidates for the standard total shoulder replacement. Sometimes if it's been a few years that somebody's been able to get their elbow overhead, it's difficult to tell what their rotator cuff function is. Even though it's intact, it may not be functionally strong. So it may still be insufficient. In such a scenario, reverse total shoulder replacement may be more appropriate. In someone like some of the pictures that I had shown, whose rotator cuff is completely gone and there's significant arthritis, reverse total shoulder is the way to go.
Again, if you have any further questions, please see the email address at the end of the presentation. We would like to give a very, very special thanks to Dr. Patel for joining us this evening. His presentation was thorough, comprehensive, impressive. I feel very well informed now. Thank you to the community for viewing as well. Join us next week for Dr. Hussein's presentation on the new world of biogenics, opening doors to orthopedic treatments. Thank you and have a good evening.